I'll get to the topic in just a second, but Michael, who was up before me, is just about to have a kid, and I think that's one of the best ways to stay grounded. And I'll tell you a little story about one of the times with general practice. So I was wearing my pager, or at this time we had progressed to cell phones, and my youngest came up to me and she said, she tapped on the cell phone, which I was wearing on my hip, and she said, "What's that, Daddy?" Because I didn't wear it otherwise. And I said, "Well, that's a phone, honey." "Well, why are you wearing it?" I said, "Well, that's in case people who need me can call me and I can try and give them some help." And she looked at me. She said, "Dad, are you a firefighter?" And I said, "No, honey, I'm a doctor." And there was this long pause, and then she said, "Well, you can't help anybody." So, the title, I'll get to the title in just a second. But I'll show you, it comes from audiences. So first of all, faculty disclosure. So this is where we have to talk about kind of the ugly side of medicine. So don't think of yourself as an ugly person. Think of yourself as a beautiful ape or monkey. So what is my background? Well, I'm a family doctor or a GP, and I am a professor. So I get money from the University of Alberta, and I get money from Alberta Health Services. I get grants and all sorts of other things, but I've never taken any money from industry. So let's get on to the topic. So how do you end up with this topic? How do you end up with a topic like this? Well, actually, it comes from my audiences. That's generally what they look like. And you get feedback from audiences over time, and you get scores which are interesting, but the best thing is the written word, what you get in the written word. So I'm going to give you some samples of what I've been called and what I've been told. Now, my stick is I go around and I talk about how evidence applies to family practice, because really, unfortunately, we don't have a lot of people really doing a lot of that, at least in Canada. So here's one of the first things I was ever told. Now, I thought that was a little hurtful. And I thought to myself, could this actually be they're referring to the fact that the topic wasn't long enough? Maybe that's it. And then I got this, and I'm not making this up. Now, that could have been anything from an old girlfriend, who knows? But that's very hurtful. And then this is my favorite feedback I've ever received, and I still don't know what it means. Dr. Allan is scary. How do you fix that? What is it that you're scary? So, and then you end up getting called a lot of things. When you talk about evidence and you look at evidence to review ideas and concepts and the way we practice, sometimes things don't bear that well against the evidence. And then you end up getting kind of accused of certain things. So let's talk about that. So I've been called, what's this? People who kind of threaten belief systems. So an iconoclast, okay? So an iconoclast is someone who attacks cherished beliefs, traditional values, and assumes they're kind of based on superstition or error. So I don't know if I do that, but it's very interesting. If you look at something and you try and shine a lens on it, and that can upset some people who have belief systems that are very strong, and you get called an iconoclast. It's a fascinating thing. Here's what I've also been called. A cynical bastard. Now I thought, what does that look like? This is what it looks like. Okay? It's a superhero, actually, and you can see there's no way in God's earth that I can fill out any part of that costume. So cynicism is bitter, sneering, distrustful, contemptuous, that kind of thing, pessimistic. And I do like the little bit in blue, though, an attitude of distrust for the integrity or professed motives of others. Because I think in general practice, we have so many people trying to talk to us and tell us what to do. I always wonder, what is their motive? What drives their thinking? And I think it's a good lens to have sometimes. Here's what else I've been called, a nihilist. Okay, what does that look like? Well, if it's a toothpaste, it's got no flavor, no color, no nothing. And it's the idea that you reject established laws and institutions, and you have a philosophy of extreme skepticism, okay? So you're not really believing anything, and you have no faith in anything. Now, here's what I'd like to be called. I'd like to be like this guy. Look at those low brows. He's skeptical. He's very concerned about what he's hearing. And this idea is you're not easily convinced and you have reservations and you like to question what our beliefs are. Okay? And this is, he does not accept your anecdotal evidence. Okay, so why be skeptical? Well, I'll ask you, if you saw this, would you believe it? Signed copy. Maybe you're skeptical too. It could be what's going on. But this guy Mencken said that to every complex problem, there's a simple answer. And it's neat, it's plausible, and it's often wrong, right? So we have to keep that in mind. So I've got a little quiz for you to ask you if you're skeptical or not, or maybe you're a cynic, okay? So the first question is, do you prefer reassuring misrepresentation to uncomfortable honesty? Which do you prefer? Okay. Now we're going to get into the more complex ones. Okay. Do you believe it's possible to make an asymptomatic person feel better? Okay. Think about it. You're doing this all the time. You're prescribing for asymptomatic people all the time. How many of you have ever given a statin in primary prevention? And we've all done that, right? And so these people are asymptomatic. It's hard to make them feel better. So all we can really do in the short term anyway is make them feel harm. So that's one of the questions. Do you believe that a person without risk can have their risk lowered? Okay. So this is another issue of people will talk, well, that person has a high cholesterol. Yes, but they're 29 and they've got no other risk factors. So it's really hard to reduce their risk. This is the cynic question now. Do you believe patients are like an ideal gas and they'll expand to fill any volume? See, now you've crossed over from skeptical to cynic. And now we'll go back. Which is more dangerous, believing what you're told without hesitation or questioning what you're told? And that's kind of the whole principle of being a bit skeptical of what we hear, okay? Now, I really like Abraham Lincoln. I think he was an amazing guy. And he said, we can complain because a rose bush has thorns, or we can rejoice because a thorn bush has roses, okay? And I like that kind of philosophy. So what we're going to do now is rather than focusing on the things that don't work, which I have, if you've heard me talk before or you've listened to our podcast, you've heard me say a lot of things like that. But it's also time to reflect on what we do in primary care that really does work, okay? And there's going to be little quizzes. There'll be pictures that give you a hint of which direction we're going. What is this? It's a ninja. And what's ninja known for? They're assassins, but what are they? Silent. So this is the silent killer. What's the silent killer? Hypertension, exactly. That's our, do you know that we market diseases? Did you know that? I didn't really know that until I've only learned that recently, really figured out. We were at a conference and we were speaking on our evidence-based shtick, but a pulmonologist was there. And he was lamenting the fact that cardiologists have a much better disease to market than they do. And I'm not making this up. This is how good it gets, really. And he said that one of the problems is they have heart attacks, which have such a great sex appeal. So his intention, at least in the Canadian pulmonary world, was through their guidelines to change COP exacerbation to lung attack, because he thought he could market it better. So I'm not making it up. It's a crazy world out there. We're here to protect our patients. Okay, so what about very high blood pressure? Look at the year of this, 1967. That's why we don't see these trials anymore. That's why a lot of the trials don't seem to show as much benefit, because this was a long time ago when we had high hypertension. In fact, the trial published 1 year before this in The Lancet was entitled The Treatment of Mild Hypertension with Propranolol. What was mild hypertension? Do you know? What was the average blood pressure in that study? 210 on 120. That was mild hypertension. Okay, so this is a trial that actually looked at outcomes. So the effect of morbidity on hypertension. The blood pressures, they used diastolic, as you know back then primarily, was 115 to 130 or so. That was the mean blood pressure, 187 on 121. They used up to 3 drugs. The average person was a 50-year-old male. And here's what they found. You don't need statistics on this. You can look at this and say, those are different. Okay, that's 5% died versus 0 in 18 months. And 33% in the placebo group had an event of some kind, from retinal hemorrhage to death, and 3% in the treatment arm. Okay? When you're treating people with very high hypertension, you are making a huge difference for them. And we can't lose sight of that, because what we end up spending so much of our time doing is quibbling about 141 versus 140. And yet this is where the money is. All right, let's talk about moderately high blood pressure. And there are a ton of trials that have looked at this with people over 160 in systolic blood pressure. The mean of these trials is around 170, and they got down to around 150. The relative reduction in cardiovascular disease was about 30 to 35%. Now that number is absolutely useless to you if you don't know where people start, Okay? You need to know where people start to know what a relative benefit is. If I tell you a relative thing is like a cost, it's like a price or, if you get something off. So if I said to you it's a 50% off the price, but it was only $1, you're saving 50 cents. It's not that meaningful. But if it's 50% off and it was $1,000, you think that was pretty meaningful. So it's where you start that really matters. And these people are higher risk. And you can see here, I don't know if this is the pointer, you can see here these are the actual percent benefits. 3 to 4% over 5 years for stroke. That's a number needed to treat of 25 or so. 5 to 6, that's a number needed to treat of 18. And up to 5% in mortality, number needed to treat of around 20. So these are big differences as well. Not as big as what we saw when the blood pressures were 190, but still a big difference. All right, what's this? I'll give you a hint. Look at that heart. It's tired. It's beaten up. It's failing. So this is heart failure. All right, so what happens in heart failure? There are 3 drugs that make a big difference in heart failure for patients. They're aldosterone antagonists like spironolactone, beta blockers, and ACE inhibitors. Those are the relative risk reductions. What's important for understanding about heart failure, it's all how bad you are at the time. What I did is I selected people who are a little bit sicker. So the average mortality per year for someone with heart failure after an admission for heart failure is 25% per year. This is a terrible disease, obviously, but that's where we make the biggest bang for our buck. And when we're prescribing, and I'll show you data later about family doctors being so important in this, but you can see the number needed to treat to prevent death for 1 year is 16. For beta blocker, it's 14, and for ACE inhibitors, 18. How many of you would have thought that ACEs were the best at this? Yeah, it's fascinating. It's so well marketed by the cardiologists, and yet they're no better than any of the other drugs. In fact, maybe a little worse, but probably the same. All right, Warfarin. Warfarin's kind of losing its popularity now, but it's important to go back and remember, because what we compare, what we're using now a lot is things like dabigatran and the new anticoagulants. But you have to remember, they have a tiny advantage versus Warfarin. What did Warfarin have versus nothing? It had a 66% relative reduction in cardiovascular disease. There's no other pill you'll give in cardiovascular treatment that has that kind of effect. And so if you look here for people with higher CHAD scores, so things like 12, you'll reduce that by 8% over 5 years. These are 1-year event rates. Remember, when you calculate cardiovascular risk for a patient, you're doing it over 5 or 10 years. When we're talking about stroke with AFib, we're talking a 1-year risk of stroke. These are big numbers, and that's where we make big differences, and we do that all the time. For 5 years, the number needed to treat to prevent a stroke vary from 2 to about 10 with Warfarin. This drug really does work. Not that dabigatran and the rest don't work, they do work. But just as our groundwork, this is where we made our biggest step. It was absolutely huge. All right, that's a little bit blurry picture. It could be just about anything from a cervix to an ear. Which reminds me, when you start to lose your sight, I have a funny story about this. So I like many people, were really struggling to accept the fact that I was losing my vision. So I had 2 events in the span of 1 week that made me surrender. I was looking in this child's ear, and I thought, my God, that looks awful. I don't know, should I phone the ambulance or what? So then I go over, and I'm starting to type to write a script. And to get typed well, I have to put my glasses on. So I put my glasses on, and I think, I'm just going to take one more look. And I go over, and I look in. It's an absolutely normal ear, because I was basically blind up close. So no more. And I told my staff this, and we all had a good laugh. And I go in, and I'm doing a pelvic exam, and I'm looking, and there is nothing for me to see. And I'm sitting there thinking, God, I have to actually get out of here. I can't see anything. And I get this tap on the shoulder, and there are my glasses. Put the glasses on. Everything was absolutely normal. And I had this epiphany, like, my God, I really need to see to do my job. All right, so otitis media. You hear a lot about not treating otitis media, and you hear a lot about not treating different infections and which ones to treat. Here in New Zealand, there's a lot of talk now about getting very aggressive about treating strep throat with good reason. But it's a very interesting thing, because I think what we lose sight of is who benefits and who doesn't. So when we're talking about cystitis, obviously that is a condition where we know we get big bang for the buck with treating antibiotics, and short course is better. If anything, long courses of antibiotics have been shown to increase recurrence rather than decrease it. Drainage of a cutaneous abscess, 86% resolved within 10 days. Topical treatment of just tinea pedis, 70% resolved within a week. It's amazing. Otitis media in high-risk kids. So it's all about targeting kids with otitis media. If you see a kid who's 2 years old with bilateral otitis media or fever or that kind of thing, the bang for the buck with those kids far exceeds the harm of antibiotics. But if you're seeing a 12-year-old with a little bit of a sore ear and the drums red, the harm will far exceed the benefit. Does that make sense? Knowing who to treat, all of these dogmatic rules in medicine, we need to be clinicians again. That's the key. All right. Does anyone know who this is? It's a fascinating guy. We have him to thank for a lot of actual medicines that we use commonly in the steroid realm. His name is Percy Julian, and he was around the 1920s. And interestingly, because of his race, he had a hard time getting a job, even though he was one of the most brilliant chemists at the time. In fact, he got hired onto a job and then was told, got a letter, follow-up letter, saying, "I'm sorry, we didn't know you were African American. We can't have you work for us." And fascinating guy. He persevered through all of that, and he's really responsible for the ability to rapidly manufacture corticosteroids so we could use them as medicines. So let's get to steroids, because even though I was at a meeting where we sit at a round table, a GP and then a whole bunch of specialists and med students who do rural practice come back and get to quiz this board, and they were asking about the use of corticosteroids in general practice, or the use of corticosteroids, and all of the specialists were, "Well, I hold back on that. You have to be so careful with those." And I said, when it came to me, I said, "I use them with reckless abandon." Because they work. All right, so for acute asthma, you can see number needed to treat of 10 for 7 days to prevent relapse. For an injection in the knee, there's really very little that works well for the knee. Exercise, things like NSAIDs, topical NSAIDs work quite well. They work as well as oral NSAIDs, but really after that, it becomes things like steroid injections, and they work well in the short term. They only work about a month. The idea that they might go to 3 months is very fortunate when it happens, but they do work very well. You can see 74% of people will have a significant reduction in their pain. You know that they work well for intranasally, for rhinitis. They work very well for that. Number needed to treat of only 5. And for rheumatoid flares, I'll explain this to you in a little bit, because these numbers don't probably mean much to you, standard mean differences, and they are kind of useless numbers. But here, to put it in context, what a standard mean difference means. When you treat rheumatoid or any kind of inflammatory arthritis with an NSAID, the standard mean difference you get, at best, is 0.3. If you give them a narcotic, something stronger like morphine, it goes up to 0.4. 15 milligrams or less of prednisone gives you 1.75. It's about 5 times better than morphine. Just a whiff of prednisone really helps these people. I don't think that's the long-term solution for them. You know, there's lots of good drugs, but it is something that we can do. All right, so people helping themselves. Here's some people helping themselves. They're doing different types of exercise. Do you get people like that decide they're going to exercise because they're going to smoke? You can't out-exercise smoking. You can't. Okay, so just some interesting things to remind us that what patients do for themselves is always more important than what we do for them. So here's this is a great trial, and you might not have heard of it. It was published in Circulation years ago, and it's angioplasty versus a bicycle. So these are people who had a single vessel disease, and they were put into this clinical trial, and they were given angioplasty for that vessel, or they were given a stationary bike. At the end of 12 months, 18% who got angioplasty had a recurrent vascular event of some kind. 12% of those who rode a bicycle. 12. That's an 18% absolute difference that trumps any drug that you've given. It's absolutely outstanding. Number needed to treat of 6 in 12 months. It's absolutely amazing. Quality of life has been so clearly linked, but this is the best study. They took just recently postmenopausal women and categorized them into 4 groups, or randomized them into 4 groups: no exercise, a moderate amount of exercise, about half of what's recommended, a full amount, and then 1.5. You give drugs and medicines all the time, and they have a very poor dose response. It's not a linear dose response curve. Most of the benefit of any drug comes on very early, and then you get just small amounts after that from adding and increasing the dose. In actual exercise, it's the only thing that has a linear dose response. So as you go up, your quality of life continues to go up in a linear, straight fashion. 7 out of 8 quality of life measures. So really, there's nothing that you can do that's important. Is that? Just asking people if they are willing to stop smoking or consider it, 2 to 3% per year will quit, just by bringing it up. That's all you have to do. Not nag at them, not do too much, just bring it up. And then for past MI, these are people who had an MI and were encouraged to stop smoking and offered a couple options. The number needed to treat, they had a 9% reduction in death over 2 years. Again, if you took all the drugs we give together post-MI, ACE inhibitor, aspirin, beta blocker, statin, they don't have the same mortality reduction as that. So it's fascinating what we do for ourselves. All right, what's wrong with this guy? Pardon? He can't use the remote. That might be it. He's watching too much TV with those clumsy hands. No, here's what he's thinking. Those were the droids I was looking for. You work under Darth Vader and you miss a call like that, things aren't going to go well. So this is depression. And we hear a lot, I don't know if you guys have heard, that antidepressants don't work in primary care or they don't work at all, blah, blah, blah. It all depends on who you're treating, and that evidence is very clear. So the more severely depressed patients respond more to antidepressants. It's not that the antidepressants really work more, it's just that placebo works less. They're not going to naturally heal themselves, or it's much less likely. So when you have a very mild depression or dysthymia that's short-term, those people can respond by themselves without doing too much. But once you get more severe depressions, then you actually, that's when medicines really have a big bang for their buck, and we can't forget that. Augmenting also helps. There's some different trials of augmenting. Antipsychotics, I'm not saying that's what you use, but that's the most studied. Okay? All right. So diabetes. Now, diabetes is a huge issue just about everywhere in the developed world. But I would suggest to you that our part of it is only part of the problem. I want to show you a couple examples. Do you know what Krispy Kreme is? They're just wicked donuts. But anyway, Team Diabetes will be selling Krispy Kreme donuts. You can't make this up. It's too good. This is beat diabetes by buying 5 Junior Frosties for $1. You might think this is absurd. But in my hometown, at the school that my child goes to, she was taking, we had a party and there were pop cans, and she was taking all the little pieces off the top of the pop cans. I said, what are you doing? We collect these for diabetes. It's a fundraising thing for, you can't. We have another picture, which I didn't show here, and it's buy 5 bags of Cheetos and get a free cholesterol check. You can't make it up. It's like we're holding back the ocean with a bucket. Okay, so this is steno. How many of you know of the steno trial? It's a great trial for us to know about for 2 reasons. One, a lot of people kind of lose hope in diabetes, and I get that. I understand why that is, but actually, in the steno trial, they did make a big impact. But the important thing is how steno was done, and that also should help us. In steno, what they did is they took a bunch of patients who were high risk. There weren't many of them. There were only 160. And then they randomized them to very aggressive management. And I mean calling them at home, visiting them at home, nagging the heck out of them. Everything was free. Constant reminders to exercise. In fact, this group in the aggressive arm exercised twice as much as the other group. They had 5 targets they were going for. 2 were in blood pressure, 2 were in cholesterol, and 1 was sugar. Now, at the end of 7 years, the trial went a total of 13, but at the end of 7 years, how many out of the 80 that were in the aggressive arm got to target, do you think? How many? 1. 1% of patients got to target. Have you ever heard that we in primary care aren't good at getting patients to target? That's because the targets, and I know this is going to shock you, are ridiculous. Okay? They're impossible to attain. In fact, the highest dose statin, the highest potency statin, will get less than 50% of people to an LDL less than 2. So you're going to bring them back for something that they have no control over, and they're taking a pill when they don't really feel bad, and you're going to tell them they're still failing. Targets are a terrible thing in medicine. It's just one of my secret beefs. But this is, it's not so secret anymore. But what's important to remember is they didn't hit targets, but they gave them the right medicines, they gave them the right interventions, and they motivated them in the right way. And the mortality went from 50% to 30%. Cardiovascular disease went from 60 to 30. And this is the only trial that ever showed a reduction in progression to dialysis. Okay? So it doesn't matter whether you're hitting targets, it matters whether you're doing the right things for your patients. And when we're talking about diabetes, one of the key features in diabetes is to remember to talk about blood pressure. It is the thing that will affect the outcomes the most for them. So when you're seeing a patient and your medical student or resident or someone comes to you and says, I'm seeing this guy, his A1C is, go, oh, I actually want to hear his blood pressure first, because that's the most important thing you can do for them. You can see the reduction with blood pressure is 25 to 50% relative risk reduction. So it will trump everything else you do. If metformin is as good as we hope it is, from a few clinical trials, some don't support it, some do, it could be as much as 35%. Statins are anywhere from 25 to 35. The rest of glycemic control is not good. The best we could hope for from long-term extended studies is maybe 15%. And ASA, you'd have to be very high risk to benefit. So it's blood pressure, blood pressure, blood pressure, metformin, blood pressure, statin, blood pressure. That's how it goes. Pardon? Aspirin. Aspirin, sorry about that. All right, pain. So do you ever see anyone with pain in your practice? We do a pretty good job of that too, actually. And here's a pain score that I thought would be helpful. So you can see this is no hurt, and this is hurts worse, but this actually allows you to take patients through where they are. How many patients have sat in front of you smiling, drinking a coffee, and said, I'm 10 out of 10? You hear that all the time, right? Have you ever gotten upset? Have you ever lost it? Michael was talking about that when you lose patients. I have. I admit that I'm not perfect on every day, hardly. And one time I was so furious by the end of the day with this patient, I said, no, 10 out of 10 pain is me slowly tearing your arm off. Where are you now? And she's like, 3. That wasn't one of my prouder moments, but there it is. So this is no hurt. You see this guy's happy. He's smiling. He's very content. That's a boo-boo. That's like a kind of 1 out of 10. Okay? That is going to sting. That's a 4 out of 10. This, having a spike driven through your hand, is a 6 out of 10. Can you imagine me doing that to somebody and then saying, now that's 10 out of 10? So, and then this is 8 out of 10, and this is the worst, okay? This, and he's not just biting that guy. Something else is going on. That is 10 out of 10 of everything right there. That is awful stuff. So, yeah, that's what 10 out of 10 looks like. So let's talk about pain really quickly. There's all sorts of things we do for pain that is actually very effective. So TCAs for any type of headache. Why I like TCAs is I don't have to sort out the nuance of is this more a migraine headache or is this more a tension headache or what is it? Because TCAs work for it all. So amitriptyline, number needed to treat of around 8 for a 50% reduction in headaches. Propranolol is about a 4. It's probably the best studied drug, but specifically really doesn't work for tension at all, just migraine type. Neuropathic pain, again, TCAs around 3 to 4, gabapentin around 6 to 8 for reduction, number needed to treat. Back pain, many people don't know this, but the cyclobenzaprines, in Canada anyway, it's kind of one of these things that everybody poo-poos and talks bad about, but actually Flexeril and cyclobenzaprine are actually effective for back pain. And NSAID's about a number needed to treat of 8. In this case, when it's back pain, there's no evidence that topical works. It has to be oral in that case. Now, I thought we'd go over also some easy tricks for patients to help you guys with your patients. So this is, I think you'll find me one of the most empathetic doctors around. But there's a few practical hints, and one of them is time. And what's interesting is it doesn't really matter whether you spend the extra time, it's if the extra time is perceived to have been spent with the patient. So that then leads to the question is, how do you lead to the illusion of spending more time? Sit down. This has been documented tons of times. If you sit down during a consultation, patients will perceive you have spent more time with them, and they'll rate the consultation higher, even if everything in it is the exact same. So what they did is they did a really interesting study one time where they had people stand, be in the room longer, and they were still perceived as having the shortest time with the patient. They were rated by the patient. So one of the tricks is always to sit whenever you can. Sometimes if you're like me, you go into the room and all the chairs are filled. Your resident has one, the patient has one, and the 7 family members have everything else to sit on, including the counter, and you're left standing. So it's not always easy, but I have been known to sit on the footstool and on the examining bed. So that's just some tricks. So what difference does a word make? This was an interesting study about getting to unmet needs of patients. I don't know if it's real. It needs to be verified by another one, but it is an interesting idea that saying, is there anything else, doesn't really seem to help. But changing that to, is there something else, somehow helps people open up more. I don't know if that's real or not, but it is an interesting one. The thing that I know has the best evidence is sitting down. All right. Now, we've gone through drugs and interventions and how to interact with people, and I thought I'd save the best for last, what really works. And that's us. Okay? I'm going to show you some evidence around us. So this is accessibility and satisfaction with your GP. 90% of the care takes place in general practice. I think you know that. And you've probably seen that Ecology of Care diagram. Was first published in New England Journal, but it's been republished, and it's exactly the same, even though it's been 20 years since it was first published. The vast majority of care that takes place for any patients in your community are through you guys. Okay? In Alberta, 90%, over 90%, felt that they had good access to their GP through the whole year. Only 3% thought that they didn't have good access and that impacted their care. Interestingly, this was a study we were doing, and I was on it, and when I got the first draft of the write-up, it was how terrible it was that 3% of people couldn't get in. Then I said to the group, how many businesses do you know that have satisfaction ratings at 90% and above? How many? Were you looking at a wide, remember, people complain. That's what we do as people, right? So to satisfy 90% of people that you have good access is pretty amazing. And then they reflected on it. Some of them were my specialist colleagues, and I said, can you say that that's the way it is in your practice? And they couldn't, so we changed the write-up. This is just an example from more Canadian data showing that of everyone in the system, family doctors are rated the most. Interestingly, this was right around the first time this was done in my province. The government had a plan to change primary care, to get more involved. And they did this big research study which showed by far, at that point, the thing that people were absolutely happiest with was general practice. What was the final decision of the document? We need to change primary care. Because once a train's on a track, that's where the train's going, right? That's the way systems often work. I want to talk about some myths. GPs don't see complicated stuff. That's not what the evidence is, actually. The evidence is that we see very complex care. In fact, the morbidity factors in our practices are higher than our specialist colleagues. Do you know one of the reasons why that is? Have you ever referred someone and they didn't go? Has that ever happened where you've sent someone to see a consultant and they didn't show up? Patients who go to a consultant have declared themselves as compliers. They said, I'm more likely to follow through with what you're recommending. So they're naturally going to do better. So they get actually, the patients that they get are often more likely to comply. GPs don't do as good a job managing conditions. Well, actually, the research doesn't support that. We don't hit targets, but as I've demonstrated to you, hitting targets is impossible when the targets are made. Impossible to hit. I thought GPs were associated with worse care than specialists. You guys have probably seen a lot of this data. This is from Barb Starfield. She's passed away now, but she led a lot of groundbreaking work in this area. I'll skip to the important parts. Areas with best primary care have better health outcomes. Areas with higher specialist supply have worse health outcomes. Okay? Now, it's not only Barb. In fact, this is a group from Vancouver who did it, and they came up with a formula. And is an increase of one primary care physician per 10,000 patients decreases or reduces deaths by 3.5. Adding one specialist increases death by 1.5. Isn't that fascinating? And yet we heard from Mike earlier, just a minute ago, how family doctors don't do a good job. We're letting people slip through the cracks. It's actually the opposite. Is there anything new? There's all sorts of new information all the time on this. This was a study that looked at breast cancer death and cancer-related death. And it found that people with a family doctor or women with a family doctor did a lot better. This was another study that looked at congestive heart failure and readmissions, and it found that people who had access to a family doctor were least likely to return to care, even more so than those who had access to a cardiologist. So you've just been in hospital for congestive heart failure, and you come out, the best person for you to follow up with is your family doctor. They're the one most likely to keep you out of hospital. This is for renal disease, and it found that the most important person to have access to, again, was the family physician. Okay? So it's very consistent. And I think it comes down to a lot of the nuances that we'll never, ever be able to measure. And I'm going to go through a case with you. This is from my practice. This poor lady has passed away, but she was 80-something almost 10 years ago. So she was at her 90s when she passed away. And she had a lot of conditions. She was a patient of mine who, when you get to the point where it's almost easier to think what is working for this poor patient versus what is not working. So she had vertebrobasilar strokes, AFib, and hypertension, which meant her blood pressure was almost impossible. Because when you would reduce it to try and stop these vertebrobasilar strokes, she'd start to fall, right? So it was a really tricky job. So vertebrobasilar strokes, AFib, hypertension, dementia, osteoarthritis, osteoporosis, anxiety, it went on. And what we did is when I looked at her, we knew that she was getting more demented, so I got quite concerned, and I thought, I'm going to go in and switch her to a dosette pack that's prepared by the pharmacist. When I do that, I always try and do a home visit with the patient for two reasons. One, it's a very unpleasant conversation to say, I think we should help you with your pills now, because they're relinquishing control of that, and it's a hard thing. On top of it, I have to go find what other pills are stashed around their house. So I play a little bit of detective and look around the house. And sometimes I've found great things. Like one family had a, I'm trying to remember the name of it, but it's a drug for worms. And they had gotten it from their home country, and they took it every time their stomach was bothering them. And it's thyrotoxic. They were all hypothyroid, fascinatingly. Surprise. So we cleaned out her place, and we brought these things home, and in the bottle marked 2 milligrams of Coumadin was this. Those are bad pictures, but those are cinnamon hearts. So she was taking her heart medicine, but it was cinnamon hearts. So when I would phone and I would say, your INR isn't quite right, we need to bump you up to 2 of the 2 milligram pills, she'd say, fine, and go pop 2 cinnamon hearts. And then her INR would slowly go down to 1, and I'd go, God, what are we doing wrong? But that was exactly what was happening. All right, discovering nature. This is on the highway coming back from one of the conferences. I love that, discover nature, and we went off the road because of nature. Okay, so one of the key things is I think no one knows your patients like you, and that leaves me with the very last thing I wanted to talk about. In a world where we're getting forced more and more, or encouraged more and more, to have targets and performance measures, I wanted to remind you where you make the biggest bang for your buck, okay? So this is different ways of looking at healthcare of what we do. Right here you can see is cancer screening. When you screen for cancer, which is in Canada where we put almost all of our performance measures, you have to screen one person for 1,000 people for 10 years or 10,000 patient years to benefit one, okay? When you do cardiovascular disease prevention, you're looking at over 5 years, you're looking at number needed to treat of around 30 to anywhere to 400. Converting that to the same numbers, you're looking at 1 every 150 to 2,000 patient years. Okay? Now you're talking about antidepressant treatments, things like that, giving antidepressants, treating constipation, treating headache, recurrent headache and chronic headache. Number needed to treat 1 in every 1 to 4 years or so. And these are actually, I'm being very generous, making these not as good as they really are. And then here with amoxicillin, shots to the knee, headache, pain that's acute, your benefits are almost immediate, and they're probably way better than once a month. Okay? So it's a 10-to-1 ratio there, at least. We are being driven more and more by bean counters to move and look at these when this is where we make the biggest bang for our buck. And what's been shown by performance measures is when we're told to do these things, we do them at the exclusion of these things, which we're the absolute best at and which are the most meaningful. How many of your patients came to you last month and said, Doc, I'm really concerned about my microalbuminuria. It's really bothering me. There's all this foam in the toilet. I don't know what I'm going to do. They don't worry about that. They're here for things that really bother them, and that's where we can make the biggest impact. So let's not lose sight of that and stay in charge of our own care. All right, I think that's it. Or maybe I'm not allowed to leave. No, that's it. There we are. These are all the ends. All right, thank you. Should I take a question, or?
Yeah, but before, I just have a small gift for Mike, and I hope that all made you feel really good about being GPs, because I thought that was a fantastic presentation that really married a lot of clinical information with some bigger picture information about why you are so important to our system. So Thank you, Mike.
Thanks. Thank you. I'm happy to take a question if there is any. I know, how far behind are we?
We're 1 minute.
Okay, so I can take a question if you don't, or we can move to our small groups. Yep. I think it all depends on where you set your target. So I'll ask people, for example, do you think this works, whatever it is, this NSAIDs, let's say. And some groups will say yes, and some groups will say no, but it's all in perspective. First of all, one of the things to remember is take shots to the knee, for example, corticosteroid shots. 75% of people get better, right, from a shot to the knee. What's the number needed to treat there? About 3. Because some people are getting better by placebo effect. And we know that injections have more of a placebo effect than a pill, interestingly enough. So you have to take in concept, when you hear number needed to treat, what you're talking about with that is, what is the actual drug benefit? But our benefit is actually more than that. So in clinical trials of depression, it's been shown that coming to see us has an impact on the outcomes themselves. So patients who are in the placebo arm, they're coming in quite regularly, they're seeing their doctor, they're getting out of the house, they're having a chance to talk about their issues, those kind of things. So when you talk about number needed to treat for a drug, you're only capturing truly the drug. You're not capturing all else that we do. So there's an element of that there too. And I also think that there's so many things that we do that are so ineffectual that when I hear a number needed to treat 1 or 2, what are 2 drugs that really do work, or 2 interventions that really work? One of the things that you do that people never want to come off of, do you know it? PPIs, or proton pump inhibitors, like Pantoloc and or pantoprazole, omeprazole, that kind of thing. For them, 90% of people will get better if they have GERD when they're given one of these drugs. 30% will get better on placebo. So you can look at the kind of thorns and say 30% of people would got better anyway. Or you can, and 10% still won't get better, or you can look at the fact that 60% were changed. What's the other drug that works? Sildenafil. Okay? Number needed to treat consistently is around 2, and number needed to harm for headache is around 3, but none ever quit. So yeah, you're right. Is it perfect? No. None of our interventions are. But it really depends on perspective, I guess, and remembering that when you saw some of the numbers I presented, I also presented the total number that benefit, like from abscess, 86% total benefit. So I think we have to, and once you're in practice for a while, you have to glom onto those numbers because they mean really a lot to you because you see a lot of things that don't work. Is there any other questions? All right, great. Thank you so much.